Good morning, everyone. Ladies and gentlemen, hello and welcome for everyone. I will say a few words in English and then switch to the Polish. And if I may, Professor Wasileva, it is nice to see you again. Houston, it was a very amazing time for me. Thank you for your time there and the wonderful workshop. And I would thank you for including me in the project. I'm very pleased to be a part of it. I'm a medical physics expert, also a radiation protection officer, and I have over 15, maybe 16 years experience in the field of diagnostic and interventional radiology. But my doctoral dissertation was about evaluation of ionizing radiation dose for staff and the personnel in cardiology and interventional radiology procedures using the symmetric system. Sorry. Today I have a lecture about my and my colleagues' work in a hospital, so let's start. I will switch my presentation right now and switch to the Polish language.
So I would like to say that I represented the Upper Silesian Medical Center in Katowice, in Giec. I mainly work as the medical physics expert, and I also coordinate radiological protection in our hospital. Just some information on our hospital. We have about 10 interventional radiology labs that have different angiographs, C-arms, they are cath labs for cardiology, invasive cardiology, interventional radiology, neuroradiology, electrophysiology, and electrocardiology. We have an operating theater for orthopedic and neurosurgical procedures. We performed some 19,000 procedures of interventional radiology per year. We have 10 angiographs. They are quite friendly to physicists. One of them is biplane. It has a tube and detector in 2 sets. The other one is floor-mounted hybrid surgical multi-axis systems. We also perform procedures in the fields of cardiology, neurology, vascular surgery, orthopedics, and neurosurgery. We perform diagnostic and treatment therapeutic procedures. So when it comes to the radiation protection officer competence and medical physics expert competence, medical physics are optimizing the radiological protection of patients and other persons who are subject to medical exposures, while the officers assist the heads of the facilities. They are responsible for compliance with the internal procedures, responsible for protection of the staff. But there's also the joint fields for these 2 experts where they meet. They can conduct quality control tests, the basic tests based on our regulations. They have to be done by the person authorized by the head of the hospital. When it comes to the use of X-ray equipment, physicists perform specialized specific tests, commissioning tests, so on and so forth. When it comes to the radiological protection, we should all realize that this protection is responsibility of the personnel, and it results from the ethical responsibility of the staff. So if the procedure is clinically successful, each dose is justified, and if not, then if doesn't matter of the dose value, this dose is not necessary. We've already heard it today and yesterday. The dose that is generated by the patient is the dose, the scattered radiation also impacts personnel. So when we protect the patient, we also reduce exposure to the staff. I'm very sorry that it's not translated into English. The key laws, once the Atomic Law Act has been amended, these are the regulations that are important for the medical physicists. So the ordinance of the Minister of Health is very important. I will be covering the regulations later on. So when it comes to the effects, we should be familiar with effects of the ionizing radiations, as Zhenya was telling us yesterday and today. So there are deterministic effects that now are referred to as the tissue effects, tissue reactions, and the other group of the effects are probabilistic ones. So, for example, a tumor can develop in future. In deterministic effects, it's the erythema, its size, so erythema reddening on the patient's skin. Of course, it's the reddening which results from the exposure to radiation. Cataract is another effect, and tumors, it's a stochastic effect, as I have said. What's the role for the medical physicist, who is also responsible for the dose? So this role is defined in the Atomic Law Act. So there are the 4 items: optimization, radiological protection of patients and other persons subjected to medical exposures, including the application and use of diagnostic reference levels where applicable. It's also about the criteria for radiological devices and auxiliary devices, analysis of events of potential exposures, and tests. We have already heard about the tests, but when we are talking about the dose optimization, the physician, the attending and the referring physicians are mainly involved. So our lawyers informed us about the interpretation of the regulation. So now we have an instruction concerning the procedure with the patients when it comes to the radiation-caused skin problems. So now there are very precise definitions of the referring and attending physician. So the approach is the referring physician is the physician who is able to refer patients to procedures that involve medical exposure, and the attending physician is somebody who is responsible for the radiation, for the exposure. So very often patients go to different units, so the attending physicians can change. That makes the interpretation of the regulations quite complicated. Medical physicists, recently, there are some requirements. Actually, they were implemented in 2023, and they laid down very precisely that medical physicists should be involved in the wards of cardiology, interventional radiology. So one physicist should be provided for 20,000 procedures. So the work that the physicist has to conduct, well, I think it's too few. One physicist per 20,000 procedures is not enough when we look at quality control, the control of the apparatus. In our hospitals, we have 19,000 procedures. I don't know whether it's a lot, but we as physicists very often have to work in the afternoons, in the evenings, to conduct control quality tests, to meet the requirements that are binding to all the entities based on the Polish legislation. We also have other requirements to meet.
Speaking of medical physicists, he or she should be involved in the optimization of exposure of persons under 16 years of age and pregnant women. So what are physicists doing? What are they dealing with? Our interventional radiologists are very much interested in effective dose, but they are not always aware that this effective dose is not the dose that is administered to the patient. Jenia yesterday explained that because it's just an estimated dose. We know how it is calculated. We estimate the dose based on the conversion coefficients. They are available in literature. We can use it for benchmarking of the equipment and optimizing the procedure. This is not a dose that has been determined for a specific patient. It can be an indicator or a dose based on which we can estimate risk related to a particular procedure, having in mind factors such as sex, age, origin. Speaking about the risk or the area of interventional radiology that we remain within, well, depending on doses, estimated doses, well, even they may be from very low to low, moderate, depending on the procedure, on complex procedures, especially if these procedures have to be repeated. If we think of interventional cardiology procedures, I show here results from publication, from ICRP publication 147, which refers to effective dose for interventional cardiology. If you have a median, it doesn't seem high, but we need to look at maximum effective doses, and here they are meaningful or significant. If we look at TAVI, or it's even 100 millisieverts. So what about pregnant women? Because I'm often called and my colleagues say, well, Joanna, listen, we have a pregnant woman and we need to carry out the procedure. What to do about it? Well, if we know that this is a pregnant patient, we have to do everything to protect the fetus. Of course, if the procedure is clinically justified, but when we don't know that the woman, that the patient is pregnant, and a dose over 20 millisieverts has been administered. It has never happened in our practice, but it may happen that they learn about being pregnant after the procedure. Then we categorize this incident as category 3. We don't want to expose pregnant patients to the dose because children are in this group, age group. So cancer induction in this group is really of minimum. Is really minimum, but the rate with which cells develop in such small organisms is very high. So in practice, if we have a pregnant patient, we have a patient of 43 years of age and the fetus was 10 months. So we carried out a pulmonary arteriography. The fetus was outside of the beam, so we X-ray beam, so we didn't have to calculate this dose. Well, I always explain this to our students. Then the fetus remains within the range of the primary X-ray beam when we can see the fetus on the screen on the monitor. But anyway, we calculated the dose for the patient and for the fetus. This is the dosimetric report. After each procedure, we have such reports. After report here we have dose area product expressed in grays. And we didn't find the conversion coefficient for thrombectomy, the procedure that was applied in this particular case. So we used the conversion factor that was dedicated to coronography. So we calculated the dose absorbed by fetus, taking into account the error of the estimation of the conversion coefficient from the literature. So the dose for the fetus allowed us to tell the future mother that it was a negligible risk because the dose was so low, and 1.6, that was the risk to the patient, but it was very low based on ICRP 147. But coming back to the doses that we as medical physicists have to cope with, and estimating the risk of stochastic effect, I have already explained to you, but how are we dealing with deterministic effects? Well, that is quite simple, because first of all, we need to understand that the peak skin dose is not equal to karma at reference point. I have this is the parameter, and this is how I denote it in my slides. Why? Because PSD is not equal to air karma reference, because for the patient this focal point should be 15 centimeters from the body of the patient, and it's not always possible. And operator, for clinical reasons, applies this side projections, which are less favorable. But this dose doesn't, this is not the same dose as the one absorbed by the patient's skin. So here you can see images obtained using radiochromatic film. We have coronography here. This is the distribution of X-ray beam. So practically we can see triangles here but this is coronarography with angioplasty. Well, angioplasty itself, or electrocardiology procedure, or angioplasty of abdominal aorta. And here in this reference, I took account of reference points compared to peak skin dose, and for coronarography, where the code for the tube, when the angle, I'm sorry, for the tube, there are different angles, but it's 150%. For the same deterministic effect, Zhenya has already discussed it, so I'm not going to go into details. What's important is that it may appear even after a year following the procedure, and there are factors that influence radiotoxicity. Some increase it, and they are denoted with pluses, while there are other which reduce it. We should look at the radiation of the same area of the patient's body in a short period of time. So if there was a procedure that was carried out before and such patients happened, and the procedure has to be repeated for almost the same area of the body, so the interventionist should take care of it. So, for example, inner surface or front side of the neck are less sensitive, but it may happen that there is loss of hair involved. You can read all these factors for yourselves, but in line with our legal regulations, we don't assess those to skin. Because it's those for the skin. It's because it's just difficult. Because there was a workshop which I attended last year, and the colleague from the Czech Republic told us that if KERMA at the reference point exceeds 6 or 7, then we need to determine or assess or estimate those for the patient's skin. There is different there is software which can be used for that. This is stent graft implantation of a patient. I'm not going to tell you about medical indications, but this is a stent graft which has side parts which, if there is serious vessel malformation, are there just not to close the vessel. So KERMA at the reference point, because these procedures are long and very complicated, so it may amount to 12 grays. So for this case, we didn't calculate it peak skin dose because the procedure was quite complex, and considering the clinical condition of the patient, it wasn't important. So factors which impact the dose or which tell us what we should take into account if we want to assess those two for the skin and compare it to KERMA, that is very well discussed in an American publication. And we need to remember that KERMA is not provided for the actual point or place where a patient's body is placed, but it's given for the air, and it doesn't consider, and it's identified for the air, not for the skin. And it doesn't take account of the radiation or backscatter radiation from the table, or so backscatter factor is also important because it also depends on the size of the field where the radiation is applied. We have a report 457. We carry out appropriate, we carry out such exams, so we correct KERMA with backscatter radiation. It's not necessarily 1/4, the value which is generally assumed. Speaking of how we cope with the estimation of those two patients for patients' skin, so we have here radiochromic film dosimetry, based on which we can identify the initial dose for the skin, and besides peak skin dose, we also identified reference levels, diagnostic reference levels, locally, but we calculate them from K parameter, but also from KERMA at the reference point. That's what we use for effective doses, and our reference levels are compared to the requirements resulting from our national regulations and European recommendations. Calibration in a clinical setting is not easy because we need to make a series of measurements and to identify the function, imaging function, based on which we can identify peak skin dose for the patient. There are diverse procedures that are used. We measure and calculate what we think we are measuring and calculating. So if we have those for the skin, if we calculate the peak skin dose from radiochromic film, we cannot make these measurements for each and every patient because each calibration may take even as long as 12 hours in a clinical setting. So we cannot perform these procedures for each patient, because if we change the film, we should calibrate it for the new film. So we have a relationship between PSD, KAP and reference KERMA, and also at the reference point we add on or consider backscatter factors. And of course we know that KERMA is calculated for the air, but we want it for the skin. So we can take account, so we apply correction factors for the K factor for different scenarios. I will tell you about it more in a while. And we also consider an option which is quite difficult if we consider a sort of homemade model, because we make measurements for which we don't have a dedicated software. So we measure the distance from the table. This is how we calculate the distance correction factor. And there is a coefficient, geometrical coefficient, which is also important. As you know, X-ray angiography apparatus is mobile. So RMC angulation, when we estimate those for the skin, it doesn't help physicists. So if we have finally, if we develop such a model, we calculate those for the patient's skin for a particular procedure with a specific KERMA at the reference point. In the next step, or in parallel, we are analyzing repeated procedures, and from cardiological or repeating procedures. So we identified a patient to whom coronarography was repeated 3 times, while KERMA at reference point was 3.2 grays. And if we're speaking of repeating procedures, we are currently analyzing procedures for interventional surgery, procedures, vascular procedures. We are currently validating this dose tracking system using diachromic films. We are currently recalculating these results, and I'm sure that we will come to some conclusions, although from the literature we can learn that the difference between the real dose or the dose identified by the film and the dose for the patient's skins given by the dose tracking system, these differences are 10% at a maximum. But because we have such a dose tracking system, we would like to confirm and validate these values.
the vascular robot, it does not make our work easy to assess doses to patients because it has a varied isocenter. It means that the reference point is floating 15 centimeters below the instrument. We've got KERMA in reference points, so there is this varied isocenter. The point for KERMA is also changing in time. That means that additionally we need to make the correction by another coefficient. So we decided that we should look for a better software that would work that would assess skin dose by using special equipment. So there are quite major differences. We've got one angiograph that assesses, calculates the dose, peak dose on skin. So we observed lots of variation in terms of KERMA in reference points. So this value is not always higher than the peak skin dose. Sometimes we can look at the differences as high as 40%. So we've got some empirical regression equation that allow us to assess the dose on patient skin. So we are using KERMA product, KERMA area product. So there are specific software that do not operate real time. They start working after the procedure has been completed, but they support us as physicists, so we are going to use such software too. In our hospital, we've got a system that investigates the peak skin dose for the patients. Currently, we are just testing this system. As you can see in the publication, there is a very good relationship between the peak skin dose. Here you can see it's plus minus 20%. Some publications state that it's 10% of compliance between the peak skin dose and the dose that effectively has been deposited on the skin. This system is interesting. It allows us to adjust, to design the dose for the patients based on his body size. So we can include all the parameters that occur during the interventional procedure. This is a report for the procedure. So there is a specific peak skin dose. So we can compare it to KERMA in reference point. This peak skin dose is here. It was smaller than the KERMA in reference points, but the difference was not significant. When it comes to the requirements we should follow, as Professor Vasilieva was telling us, there are several levels of reaction. So the first notification level, then there is the second one. It mentions the increments. So we are looking here at the increase by a specific value in comparison to the first level. And there are some specific reactions that should follow. Reports and NCRP report number 168 states that product KERMA area refers to the area of 100 square centimeters. So if the area is smaller, we need to adjust this area. We heard it yesterday, so the time of exposure is not the right level because we've got equipment and programs that operate using high dose power or smaller power. So the fluoroscopy time is a parameter that can support us. It's also possible to compare two types of equipment, of devices, if similar procedures have been performed. And one of the device, of course, for similar patients, so if one of the devices generated a higher dose, we can consider why it has happened. So in our hospital, we have a process, we are implementing this process And this is not a straightforward matter because there are several regulations that identify specific levels. Additionally, we have personnel, we have to cooperate with them, we have to implement some procedures, but we've developed a model. So, based on the instructions, we've got the forms notifying of the exceeded doses. So, if technicians know the level, they know when a medical physicist should be notified, and the physicist should verify the results in extreme conditions. He can analyze even DICOMs. So, if it is detected that during the treatment received the dose above 1.7 grays or 170 grays per square centimeter, they receive the information notification that the medical documentation of the patient should include this information. So again, we have to involve the referring and attending physicians in such activities. So if the Kerr-Marine reference point is exceeded and if the patient received a diagnostic procedure, however, this diagnostic procedure involved the dose of over 5 gray in the reference point, and if the procedure is justified clinically, then we should not treat this as an unintended exposure, because the doctor can write down that it was justified for this procedure in terms of the clinics. Of course, we have to look at category 2 events, and for example, if the values of the diagnostic reference levels have been exceeded 4 times, the doctor can write it down in the report. But if we have patients who during the interventions receive Kerma above 5 grays, the feedback is provided to the laboratory, and also we have to fill in a report on assessment of the skin, patient's skin. So if we discover that the patients keep coming back within 1 month, then we have to refer to this form on the skin quality assessment, and the physician who consults such patient is required to fill in the information in the report if some skin changes have been notified, and then we are required to register this category 2 of unintended events. However, we have not had such a case in our hospital yet. We had some notifications. However, physicians did not confirm any changes, any defects to the skin, second degree defects to the damage to the skin. So we haven't had such situations when the doses have been exceeded, and we discovered that it was not necessary to assess his or her skin. So I'm sorry that I have added some fragments of this report on skin assessment. It's not in Polish, it's not in English, sorry. So what does this form cover? So verifications, physicist verifications confirmed that this apparatus does not administer the dose which is harmful to skin, so we modify the contents. So the doses, when it comes to Kerr-Marine reference point, are observed. We analyze these doses very carefully. Surveillance of the dose. There's a regulation of the Ministry of Health on the detailed scope of internal clinical audits and external audits and the template of the reports. When it comes to interventional radiology, we have a specific system in our hospital. We've got a team of experts who deliver the audits. They are physicians, radiologists. Our main auditor assigns them a sample of procedures that have to be verified. So the physicians, together with the radiological technicians, check whether all the requirements are met. Actually, I have marked these requirements in black. This is for the physicians, and physicists check the requirements concerning audits, and this is marked with green color. This is done for the overall group of patients. Then we have the annual assessment. We check the typical median doses in connection with the reference levels. We have our own local reference levels, and we analyze the cases where some unexpected clinical symptoms arise. So we also look at the number of procedures where the total air karma has been exceeded by 5 grays. However, we do not analyze the product of the dose and area. It's problematic due to the time constraints. However, this is something we are going to implement in near future. This value of 500 is for 500 square centimeters. We also meet a LARA principle by marking the diagnostic reference level. So, and we also stress that the dose management is as important as reaching the clinical objective. These levels are defined in our Atomic Law Act. So these are the levels in radiodiagnostic practices for typical examinations for groups of standard-sized patients or standard phantoms for broadly defined types of the equipment. They should not be exceeded during routine operations. When it comes to the scope of our reference levels, they are laid down in the regulation of the Minister of Health dated on the 6th of December 2022, and the number of procedures for the levels is quite limited. Students who write the doctoral dissertation under my supervision, they identify our internal diagnostic reference levels. So we assess exposure to patients, and we compare these levels to the levels laid down in the regulation. Of course, we do it for different procedures. For example, for interventional cardiology, vascular surgery, because we know that there's a lot to do. We know that these procedures involve high doses, and also we work on the doses in neuroradiology. The role of the medical physics, something to add to what Professor Vasilieva was saying, it's the quality control. This is something that should be done by our staff, by the physicists. Of course, it's a matter of appropriate equipment. Here you can see some images taken during 6 monthly tests or quarterly tests. I'm looking at the time. How much time have I got to finish my presentation? So we do the test. We check the grid, anti-scatter grid. We take some pictures. We also check the X-ray equipment. We check the dose capacity. Geometry is not that important, but we check whether the results are repeatable. And there are also some tests that have to be done daily. So this is something that should be remembered by medical physicists, technicians. So maybe once a week the quality of the screens, monitors should be checked. Daily inspections maybe are not necessary. However, the monitors should be checked. We should follow different guidelines. American Association of Medical Physicists actually issued some guidelines. There is a specific task group responsible for this aspects. We are also implemented other methods of measurements. So we using angiographs to conduct diagnostic tests, again to meet the requirements of the Minister of Health. We would also like to use other tests, the exposure control test. We would also like to conduct test of the settings of the equipment, tests of different programs used for clinical exams. I have mentioned that one physicist is responsible for 20,000 procedures. In our hospital, we have 4 medical physicists. They are involved only in radiological imaging. So still, they are quite busy because they have to assess the dose. So it's very time consuming. But we're making time for this. We are looking for ISO center in the devices, even though it's not laid down in the technical details. We are also trying to check the algorithms that are included in our angiograph, how to remove artifact. We also make our own phantoms. We cooperate with the orthopedics clinic. We prepare the phantom. We compare the algorithm from a angiograph with the algorithm received from the CT. So rotational angiography tests are also done. We should also calibrate, check calibration coefficients. You can see these coefficients in this slide. They can be identified in a straightforward manner. So we need to know the area. You can find this information in the radiographs. There are various methods and approaches how to compare the product between karma and area. We can also use DAP parameters, but we need to remember that the company is responsible for the inspection of the DAP and KAP. Not always they inspect the tables for the patients, and they do not conduct their procedures on the table with a matrix. So here you can see some coefficients for different types of devices. We don't have this device anymore in our hospital, so specific coefficients have been identified there. They are close to 1. Here you can see that the table itself is tested, and in the last column you could see the data with the matrix table with the matrix. So cooperation with personnel is of key importance in our hospital.
We have 470 persons actively engaged in radiological procedures or cardiological procedures. So training such a group of people is really a challenge. So I also Well, who is responsible for those optimization? Well, it's head of the healthcare unit, and I'm explaining that to the staff at the hospital that it's not only, well, the exposed population is not just the general population, but also the staff of the hospital, even the medical, even the staff who is not involved and engaged in radiation procedures, in radiological procedures. So radiological protection used by interventionists, using curtains, shields. This is the protection which results from the responsibility, ethical responsibility vis-à-vis others. Well, in Polish legislation, we have limit doses, that is 20 millisieverts per year, but the we divide the staff into A and B category, and for eye lenses, if we go above 15 millisieverts, this is the dose to the eyes lenses, we may categorize such a member of staff in category A. But the staff, they have to wear dosimeters. There are different problems with that for various reasons, but we may estimate the hazard and the risk to eyes lenses from the readings from the dosimeters. But if they don't use dosimeters, we cannot estimate the absorbed dose. Well, when it comes to the role of the radiation protection officer, it's, of course, his obligations, his responsibilities are identified in the atomic law, but there are obligations, there are also, he has some rights, well, but of course he must train the personnel, train the staff. We are currently starting the training courses, especially for interventional cardiology, interventional radiology, the selection of the proper equipment, the use of measuring equipment for scattering, for scattered radiation. And when it comes to the shields, we have 10 radiation protection officers. They need to control all these shields using radiograms or X-ray equipment, or using CT equipment. Of course, all these shields and protective equipment must be stored properly. These are photographs taken for this particular presentation at the lab, where we pay a lot of attention for the for the protective shields to be hanged, because they don't get damaged then, and also for angulation, for angiography, we use shields on the face or glasses. They have to be quite tight. All the shields should be rather tight, and they also should be adequate for the body posture, body position of the operator. Because if we have vascular surgery and the operator is on the first line, for this operator we use shields with higher lead equivalent than for the assisting nurse, for example, or for technicians who come to the lab just for a short period of time. And we also carried out measurements in our hospital as part of my PhD thesis. Well, I asked the physicians to use and to wear dosimeters. Report ICRP 139 report, it's wonderful because it tells about exposure, it informs about the exposure of interventional radiologists, eyes lenses. So in a research model with lens dosimetry using glasses which partially cover the eyes, these are shields, face shields for protective shields for a nurse. This is the geometry of radiation for the staff. And we showed that the highest dose received was that of the surgeon to his eyes lenses, close to 9 millisieverts. For all cases, if glasses were worn, 5-7 per year, but we have quite high standard deviation. We know why the nurses, according to our study, their exposure is relatively low. We also calculated conversion coefficient. Well, we can of course link KAP parameter with Kerma at reference point. We can then transfer it, or if lenses, if dosimeters are not used for lenses, so from ICRP 139 report, we found a value for average dose to the lens of the eye. It's between 40 to 60 millisieverts per procedures. We had somewhat higher, a little bit higher doses, but in summary, the lessons, what I would like you to take away from my presentation, I think that this is just a breakthrough subject, and radiation protection officers and medical physics have a lot to do, but they will not, but of course also interventionists have a lot to do, but they will not do much without technicians and skilled and properly prepared staff. Thank you very much for this very comprehensive presentation, showing us the view of a medical physicist. Before we start our discussion, I would like to just make some comments to your presentations. Well, the first thing is what you discussed, that we have too few physicists, 20,000 procedures per one physicist employed. I'd like to stress that what you referred to are minimum requirements. These are minimum requirements needed to be allowed to carry out these procedures. For a good practice, if you believe that 20,000 is too many, you have more physicists as in your unit. This is good practice. So I wouldn't like to compare these two aspects. But next, quality control tests. What we read in the regulations and what we have in the regulations are tests which should eliminate equipment and devices which shouldn't be used in medical exposure. Well, the quality control issue is also relates to good quality, to good practice. Well, quality control and quality assurance. And speaking of quality control tests, I'd like to invite Polish Society of Medical Physics and you personally to take part in the development of tests that are required by our national regulations. Well, I have some other comments also, but maybe they would. I will come back with them during the discussion. Well, thank you. Thank you very much for this comment. Yes, these are minimum requirements, but very often employers look at these minimum requirements for the detriment of the patients, often, I believe. Well, exactly the same minimum requirements are formulated for medical staff. I'm convinced that physicians do not or hospital management doesn't look at physicians the same way they look at medical physicists. You have definitely many more physicians than what is provided for, what would be provided for by minimum requirements, and the same should apply to medical physicists because we need to combine good medical practice with good radiological protection practice.
Zhenya, have you any comments to this particular
of
lecture?
Course.
Of course.
Thank you very much, because you know this topic is very close to my heart. Medical physics role and medical physicist involvement in diagnostic radiology. It's very challenging topic for many countries, and I understand also here in Poland. Maybe you can consider using for some estimation the recent IAEA publication in the staffing levels for the medical physicist in diagnostic radiology and nuclear medicine, because it's not just based on the procedure numbers, it's based on the equipment type, of the number of procedure, type of equipment you have. So it's quite a complex approach, and it has been compared, because there are also some guidelines from the APM, from some other organizations, and the IAEA staffing levels considered to be very, let's say, realistic, close to the real needs. Because, for example, the European Commission recommendations on the medical physics expert is seen as overestimating the need of, I mean, it's too ambitious, let's say. And I know that this is a big problem for many countries, and it's a complex issue requiring proper educational system for medical physicists at the university level, and also clinical training to be properly organized, because to become clinically qualified medical physicist, there is a need of proper university education in medical physics on the top of the basic education, and then clinical training under supervision of a qualified medical physicist. So every country organizes, adapts this to the local needs, to the local system, local framework. I don't know exactly how it's organized in Poland, but can understand from the discussions in the last 2 days that there might be a field and possibility for improvement. And maybe you can know that the IAEA has a regional project on medical physics in diagnostic radiology, through which expert support could be also maybe requested, and some trainings are provided, some other opportunities. So I encourage the Medical Physics Society maybe to be more closely involved. I don't remember who is the counterpart from Poland in this project. It's a rare 6042.
I don't remember, but we'll see.
Check. You can check, and maybe you can contact my colleague Olivera Sirai, who was yesterday in the opening, because Olivera is the technical officer for this regional project as well.
Zhenya, thank you very much for your comment. And yes, there are very big differences in the approach to all questions related to European BSS, because there are some flexibility in implementation of the statements in this BSS. And we are at the beginning to change the meaning of the regulations. I mean, we have some minimal requirements in regulations, and there is the lack of guidelines or some positions of, for example, Polish Society of Medical Physicists. So yes, we expect that, and I hope that close collaboration with the societies, professional societies, will improve the understanding of the role of ionizing radiation in medical practice at all. I mean, it's in medical questions and radiation protection of patient and staff. Yeah, this is a short comment.